Hello, everyone, and welcome back to our clinical corner. My name is Nicola. I'm an occupational therapist, and we welcome you here today to our clinical corner episode 4. And today we are focusing on that 24-hour care approach. So before I suppose allow my guests here, not my guests, but for the rest of the team here to introduce themselves, just a little bit of housekeeping. So it is a live discussion here today, and if you have any questions, we really encourage you to pop them into the chat so we can have an open discussion here. Everyone will be on mute, but as I say, pop the questions into the chat. And yeah, we hope you enjoy the conversation. So this session will be recorded, so if you have to pop out midway, that's no problem. The session will be sent out to you. So as I say, my name is Nicola. I'm an occupational therapist, and I've been working for Accora for the past maybe 18 months now, and really enjoy the role in and around education, training, both online and face-to-face. Jane, I'll let you introduce yourself.
Thank you. Good morning, everybody. My name's Jane Brewer, and I'm an occupational therapist too. I have a similar role to Nicola, taking part in the training, both face-to-face and online. We also carry out seating assessments, so we keep our clinical hand in, and working with innovation in developing new products. So my background has been as a community occupational therapist and also within equipment stores.
Who's next?
Hi, my name's Sarah Thompson, and I'm a tissue viability nurse. Same with these guys. I'm within the clinical team here, providing support, education for customers, patients, service users, anyone. My background, I was actually thinking about this the other day. I have been in care, not in care myself, looking after people since I left school. So I've gone through various things: care in the community, acute setting, community setting as a TVN and as a nurse. So yeah, quite a varied experience.
Brilliant.
Nice, thanks. My name's Chris Seal. I'm the account manager for the Southeast. I started at Accora as a product specialist. I was a PS for about 5 years. I've just caught myself on the camera up there, and I also have the shiniest forehead known to man. So I'm going to ask my colleagues to kick it off. Why has no one told me I'm looking this shiny? What?
I do have some powder.
Yeah, we should have done makeup beforehand. Next time.
We'll get the blusher brush out and
Thank
turn
you.
it down for you.
Yes. Well, as I say, this is our 4th episode in our clinical corner. And if anyone watched our last session, it was about 2 weeks ago, we did end the session on a plan to have a sing-song. So we're hoping Victoria's out there. Maybe she is, maybe she's not. So hi to Victoria, if you're there. And I'm going to put it over. Who's up? Who's first for the sing-song?
I don't want to do that.
Yeah,
I wouldn't want to do that to anyone.
I think we might lose some people, won't we? Then all of a sudden our numbers will go down.
Next time.
It'll have to be me then, right? Not really. But yeah, we would love to hear from you and where you're coming from. So pop it into the chat. Tell us where you're coming from in the country, and we'd love to hear from you. And as you guys are popping that in, we'll kind of kick this off. So today we're focusing in and around what we have explored over this last quarter. So the team has been in around that 24-hour care approach, and we've put out lots of different webinars, lots of different blog posts, etc., which is available on our Core Academy. So we really encourage you to link into that to see what we've been up to. But I suppose I'm going to kind of ask you guys, what is it over the last, I suppose we've done lots of webinars. So I know our first webinar in the series was in around that smarter 24-hour care, thinking about that person-centered approach. So what is it we've learned, I suppose, as a team when we think about that 24-hour approach?
Can we just
Yeah, go for it.
I was just thinking about, I really enjoyed the last podcast we did about the person-centered approach, and then kind of taking that into 24-hour care. It's like finding out about that person, you know, what are their abilities, what are their strengths, and what their 24 hours looks like, isn't it, really? You know, what activities do they want to be able to do over that whole 24 hours, and then, you know, where are they spending that? How much of time are they spending in the chair? How much of time are they spending in the bed? And then how, if they're spending more time in one area than the other, how can we facilitate that to be spread equally? You know, what pieces of equipment are they interacting with? in that 24 hours, and what surfaces for you are they sitting on? So it's using both those things, isn't it? The person-centered to find out about that whole person's 24-hour picture.
Yeah, and I know in that last session as well, Jane, you really spoke about that client who really loved gardening. It was about adapting that to what she enjoyed and loved.
Yeah.
And I think that really fits into nicely with Lydia's question, her pre-submitted question. And that was, do you have an approach to setting goals for residents with progressive conditions where improvement isn't realistically possible? So it's about, looking at what does that person want? What does that day look like, right? As you say.
Yeah.
So when we think about goals, how do you approach that? What would you do to support someone in setting meaningful goals?
Yeah, I think it's just finding out about them, isn't it? About what they want to really achieve, what are their strengths and that. And then I think it was Lydia saying that somebody can't articulate properly what their goals are. So it's finding about how best can they communicate, giving them the resources so that they can communicate, if it's just yes, no answers and that. And then obviously it's also setting those realistic goals as well. So if that person is lacking capacity, finding out from family, friends, the MDT as well, what do they want to achieve, and trying to do what's in their best interests.
Yeah, for sure. I mean, I always kind of go back as well with my experience when I was in NHS in the oncology wards, and there was quite a young lady, and she was only in her late 40s, and she had quite aggressive cancer, so a very short was poor prognosis, and she had young children, and functionally, like, she was very physically able, so she could mobilize quite well, she could independently get herself washed and dressed, and all she wanted to do was be able to spend time with her family. So it was actually just looking at that goal, and a part of that was to step outside the ward, because it was head and neck surgery, so she had quite extensive facial surgery, and so it was just about that, making small steps, so she could achieve that end goal, and eventually we got outside, and funny enough, we were in a garden again. She really liked spending time in that garden, and she was just really grateful for someone to be able to just spend that time and listen and just I suppose bring her back into that a setting and building her confidence up, just to step outside that ward. Because she was quite fearful. I'm going on now, but she was quite fearful of actually her young children, seeing her after this, quite extensive surgery. So it was about building up that confidence and I suppose self-confidence and body image. That's the words that comes to mind.
Absolutely. My kind of experience is a bit of a personal experience. So with progressive conditions, one of my family members actually has Parkinson's and has done for the last 30 years, maybe even more. And it's been a really slow, gradual decrease in function, in movement, in so many things. And I think, was it Lydia that asked about how we set goals for those sorts of things? It is setting small goals that are realistic at that moment in time, because so for example, my family member, sometimes they can walk, sometimes they can't, and he's very, very fiercely independent. So sometimes we just say, getting dressed, getting your shower in the morning, so what if it's the afternoon? If that's when you can walk, do it then. That keeps your independence when your mobility is at that point. So for progressive illnesses, you've just got to kind of go with what they can do at that time. But also you'll get to know, I know we were talking about residents, so I'm assuming they're in a care home. You'll know your residents, you'll know the family, and it's asking questions, and it's going back, to what do they want, what's important to them.
It's that meaningful, isn't it? So a blog post that I did was in and around that SMART goal setting, and sometimes the SMART goals can become, I remember just finding them quite painful, really. Specific, measurable, etc. And actually, let's just step back and think, what is meaningful for that person? What do they want to do that's going to make their day look good and bright?
And I think it's good to have that long-term goal, isn't it, for somebody, something to work for. it's using our skills to try and break that down,
Yeah.
to make an achievable step for that person.
I think same scenario. So my family member didn't want to have like a Zimmer frame, or didn't want to have certain tools that would make him look kind of disabled.
Yes.
At one point during his illness, and actually talking to him and saying, actually, this is going to make you more independent. It's having those conversations, isn't it? And you can feel how they would feel putting yourself in their place. But if you've got this frame, then you can then get from A to B safely, and you're not going to fall. And you're kind of looking at that in that sort of scenario, and we can see it. And then eventually, they will to make them more independent.
How would you go about breaking down like a big goal? I remember the one that sticks with me the most is when I was a product specialist, there was a gentleman who his goal that he set was he wanted to die in his chair with his daughter on his lap, which is really, really sad. And the OT was there to facilitate that. That was like his big goal. He was late stage motor neurons. He's actually quite a young dad. It was really heartbreaking. But to get there, it wasn't just get him into a chair and get him into the living room. It was, he'd been bedbound for a long time. He was losing range at some of his joints. He had to have a chair assessment. He was getting some treatment. Even like to the house, the doorway to get him through into the living room. There's a lot of stuff. How would you, because you said the small goals are what it takes to get to that big goal. Is there anything that you do with that?
Well, I think when you think, if for someone to be able to sit out into seating, right, your core is that core strength, isn't it? And
there's a lot of things go into it, right?
Yeah, so there's a lot that goes into it, but like, let's make it meaningful. So for someone to practice that sitting up tolerance, then it's a bit boring, isn't it? But let's make it meaningful. Let's get a task in there that they're going to enjoy. Maybe is it playing a game, of a board game with their daughter,
and it's over time, isn't it?
And over time, building it up over time.
Yeah.
So that each time they have, you're practicing sitting balance, you're just stretching people that little bit more. Maybe not so much with people with that progressive injury, but if you're rehabbing somebody, I remember I would put like cones in front of them to reach for, and if they did that 3 or 4 times, I've moved the cone a little bit further away.
Or even just keeping their table a bit further away. Because you see people have their life on their table, or even just changing the side. People would hate it, but I'd always see OTs.
Sarah would love that, because you always like get up and move.
I always, I say this in my training all the time. We all know that one patient that we've been to that has their chair, their table beside them, with everything on it, the sandwiches, the drink for the day, the cat, the remote control,
the cat.
And the cushion that they should be sitting on, And you do. And I actually did have one patient once that asked if he could have the fridge next to him, and I said, absolutely not. You've got mobility. I know it's a struggle to get to the fridge, but please keep going to that fridge, because that's going to keep you going for longer. Building your body to last, you know. You
and
have
in that
to
24-hour picture, you can build in then like times that he would have to go to the fridge, wouldn't you? That make that your little bit of exercise to go to the fridge and get what you want.
It's like when people don't drink because they don't want to go to the toilet because it's a struggle, and I really do get that. But it's looking at exactly what you've just said, doing that, but also kind of taking a step back, literally looking at someone's legs. I did a webinar recently on starting with the legs. Are their legs swollen? Is that a restriction to their mobility? So there might be other little things that we're not looking at, but we could do something.
It's that holistic approach, isn't it? Everything. Well, I'm going to pop a question out there now as well, because if we think about, we do a lot of assessments in care home groups, and sometimes we see patients that have been bedbound or have been in bed for quite some time, or sometimes, patients get discharged and unfortunately they don't have seating when they get home, so they spend a lot of time in bed. So how do we go about that then, getting people used to sitting out of bed again? What approach would you take, Jane, with that, if someone's been in bed quite a long time?
If they've been I want to build up their sitting tolerance in bed. I think that even before we think about getting seating involved, let's use the functions of the bed. Get them into that chair position. That can build up their sitting tolerance and give them activities to do in that while they're sitting up in bed, rather than just bring up the backrest. and things like that, you know, get them into that seated position, get them more functional, build up that tolerance, and then when time comes to bring that chair, then they're a bit more ready for that, aren't they?
On that, something else I often say in my training, so sitting up in bed, even if you have like a little bit of knee break, is quite hard. If you imagine, you know, sitting up, you've got your legs out in front of you. So that's where you maybe could look at equipment and get the one that's got reverse. Use that. So you are in an effectively more of a sitting position. So that might be, again, it's a tool. If you haven't got that on your bed, maybe think about getting something like that.
So using the equipment to empower the situation, empower that person.
And then I think, going back, because we're on 24 hours, one thing I think as well is, if you're spending all that time with the product specialist when they come and do that joint visit, and you're spending that hour and you're getting the chair set up for that person, so you might have altered the back rest cushions to accommodate maybe a kyphosis, or put some lateral supports in to stop that lean. We've got to do that throughout every piece of equipment that they're interacting with over that 24 hours. So, you know, have we got their shower chair with like a tension adjustable backrest to accommodate the kyphosis? Are we putting pillows in bed to help to support them so they don't lean? So it's making that 24-hour those interventions in the chair last all the 24 hours, because all that work they've done with you, Chris, on that joint visit is going to be undone when it goes out the window, doesn't it?
Yeah. And when maybe people can let us know if they've attended our conference in, is that end of March? Beginning of
in Watford?
In Watford. And we had Mr. Yodi Clark all the way from Belgium come and talk in and around dementia clients and that paratonia. And often we see that, right, when we go into the care home group, and people are in that fetal position. So it's about making sure that we can support them in bed, so then they can engage in tasks throughout the day, right? So it's, again, looking at that 24 positioning.
Can I ask a question? And I've just thought of this now, and I think this could be something we could do, and maybe some homework for everyone.
Are you giving us more work to do, Chris?
I'm giving you more work. You don't look busy enough.
I'm going home.
Have you ever looked at your own 24-hour clock?
Oh, I have.
I'm thinking about my own one, and I spend a lot of time driving. When I get in my sofa at home, I'm like this.
That's a lovely view.
My postural care, if I looked at it, I'm too tall for my bed, so I have to sleep a little bit the wrong way. We should do that ourselves. Have you done it for yourself?
So I've got a trapped nerve in my shoulder at the moment, and I'm literally looking at every single part of my day to figure out what's gone wrong with my posture and everything. And I've just got a new car. That's part of it. And I'm pulling down my boot. I'm doing all of this. And and it's I've had conversations with people during training, and people that sleep on their front, they get neck pain
really
and
bad
things.
for you.
It really is.
I watched a webinar recently from NBE, so National Back Exchange. They had a really good webinar in around actually sleep positionings, not for those complex postures or things, but just for the normal person, for us. So how it's so important to sleep in good positions. So it's super important.
Absolutely.
Jane, maybe you remember this with Mark the other day, and he was saying that he was examining his own posture in bed, and he had like 10 pillows to support him. So Mark, if you listen back to this, thank you for that.
Not shy.
Does he?
And he's what, 6'2" or 3 or 4?
No, he's 6'8", isn't he?
Oh, 6'8".
Yeah, I'm 6'3". He's massive.
So about him supporting himself in bed. I sleep with a pillow between my knees. Because I get a pain in my hip.
Got a proper pillow for
I purchased a proper one that straps to your leg, because when you're inside lying, obviously your leg comes over, and that was causing me a bit of back pain. So when I bought one, you can strap it to your leg on Amazon.
Isn't it funny? Isn't it funny though? We're saying all this, and it's only when you start getting a bit of a niggle or whatever, and then we start.
And then you start looking at your own 24-hour.
But yet we're always talking prevention.
But you're right. The OTs out there are probably screaming that what you've said is activity analysis, isn't it? Looking at your 24-hour picture and all the activities, you were breaking it down to find out the pain. That's what OTs do around activity analysis, don't we? Break down.
Sing for us, Jay. You're singing for us.
I love activity analysis, don't
you?
Getting the activity, breaking it down. What components do we need within ourselves to do it? what are we struggling with? How
Yeah.
can we adapt that activity to make it
Yeah.
better for that
Every day's
individual
school
to
day.
achieve
Yeah.
it? So he's an OT in
At heart.
underneath. aren't
Yeah,
you?
definitely. But you know what it is? We're people who are very capable of moving and getting up, and
Yeah.
and that. But those people who can't.
Yeah.
Yeah.
So this is another conversation I've had recently. You know, when you're trying out cushions and mattresses and things, someone said to me this mattress, oh, it's so comfortable, it's so comfortable. And I said, yeah, it's comfortable, but you can move.
Yeah,
So how comfortable is it if you're in one position?
Yeah.
Because there's certain aspects that I question as a TBN with a certain mattress, and I'm just like, you can move.
yeah.
However,
yeah.
if you can't, do you feel certain aspects of this mattress? So it's very interesting. It's like when we get new pillows, you know, it's getting used to something,
You have to adapt to it,
but
right?
you adapt to
yeah,
it.
yeah.
But
Make your
again, we
mold.
can move.
Yeah.
Yeah, yeah,
You have to make your mold, right?
yeah.
Yeah. I mean, that was that's one question.
Yeah.
We
You know
digressed a
what?
little bit there.
Yeah, we've had a busy week, I suppose. We've been at a conference this week, so we were a little bit flagging, but one question has
Yeah.
got us
There we
going,
go.
right? And it just shows that it's such an important topic to be talking about,
Yeah.
24-hour approach,
Yeah.
and not just focusing on one element to someone's care, but it's thinking about that person as a whole across that 24-hour
And
our
keep being
picture.
clinically curious.
Clinically curious. I like that. Yeah. I really hope that people are popping some questions into the chat. And hi to some of the OTs out there are popping in their names. So hi to Jane, OT in Cornwall,
Oh,
Hello,
Millie.
Millie. I
Wendy,
think
We know Millie.
Jenna. Oh, you know someone? Millie. Is it Millie?
Millie,
Did you say Millie? Yeah.
Hi, Millie. I saw. I
Emma.
think is Julie on as well. Julie
Hi,
Edwards. I was speaking to
Julie.
her yesterday.
So if you have any questions, please pop them into the chat there. Petra. Nice. So it's kind of coming from everywhere and anywhere. So Kent, Cornwall, Bristol, Dorset. Hi, everyone. I think I saw earlier as well. Did I see Ireland? Maybe I did, maybe I didn't. I'm just hoping. I mean, my
Hoping for
fellow
another sing song, weren't you?
Victoria,
Victoria, where are you?
But yeah, another question that had been submitted in earlier is what advice? Now, this is a good question, I think. What is your advice when a resident's family wants something different from what the resident themselves want?
I've had this one quite a lot.
Yeah.
And it's often in I do a lot of work in care homes, so I see residents come in, their family come in, and they see their loved one in bed. And I had one in particular. This was some years ago now, and this lady had pressure areas, pressure ulcers, and the family desperately wanted her in the chair all day, every day, and they just, I don't know if they just hadn't had that conversation with staff, but they were adamant they wanted her in the chair and out of, out in the environment. And it's, she was obviously a lady that used to love getting out there. And it was only until I came in, I was dressing the wound, and I met up with the family, and I kind of, just having a conversation. And I said, well, I can't really heal these pressure ulcers or do anything with them that I'd like to do, because she is sitting on them for so long. And actually, sitting for a long period can be really quite uncomfortable, especially if you've got a pressure area. And they just kind of went, oh yeah, of course. And for something that's quite obvious to us, they just wanted their loved one to be up, out, involved with life.
It's a misunderstanding, isn't it?
Yeah.
Not really.
But she still got up. But she was having rest after lunch. She was having some bed rest when you get those non-verbal signals. When you could see,
was she non-verbal, like cognitive? Right, okay. I've seen them before when I've been a PS, and I actually think it's a minefield for patients, right? So they are, used to doing it one way, but now they need additional support. So they've got an OT, maybe a physio as well, doing rehab. The TVN or the nursing team is going to be there. Then you've got their family members saying you don't look right. Sometimes there was just some patients just like, just leave me alone. I just want to, sit in this way. And I think from the family member one's interesting, because the clinicians really, it's like medically what is going to be best for that patient, therapeutically, sorry. But sometimes patients' families, I saw some real tricky ones. Like
Yeah.
We
I
don't
mean,
like chair, we don't like the
I
camera.
think just going back to your point there is in and around that information, and I'm going to reel TVM now, but the asking bundle.
Yeah.
And what's the last point of the asking bundle?
Giving information.
Giving information. Yeah.
I think
And
it
as
is
OTs,
education.
it's about
It's
education and advising
Yeah.
people of what's happening.
Serious brownie points for dropping asking
true.
bundle.
I know.
She's got a gold star for doing that one. Gold star for doing that one. But it is education, isn't it? It's education coming in. And I think I've always wanted to be open and honest as well with my patients and their families.
Yes.
About, this is what we're trying to achieve for mum or dad. We might not quite get there, but we're doing our best.
Yeah.
And then that just, sets everybody's expectations.
And what is meaningful to the person. I remember when I was out in the community, and I remember seeing this frail lady, and there was a physio involved, so sorry for the physio to her. And then the elderly husband as well, and the husband was quite keen, let's get her up, let's get her sitting out into her chair, let's keep going, let's keep her moving. And the physio had a great plan to do the sit to stand exercise, and they brought me in to review the transfer method. And then we did one stand, and I just had to stop the session, and I just said, hold on here. And I just said to Mary, the patient, I was like, Mary, do you want to do this? Is this what you want? And she was like, no,
Oh, bless her.
I just want to go to bed. I want to play cards in bed with my husband. And for him, that's all he wanted to just get up and he thought was really good to bring her out into the chair. But all she wanted to do was be in bed and be comfortable and feel safe and secure. And actually, sadly, she passed like a week later. So think what is meaningful for that person who's coming to the end of
last
their
week
stay.
of her life.
What does quality of life look for that person?
Sometimes your body just exhausts, doesn't it?
Yeah.
And actually, hopefully people can usually tell us. But
it's about advocating for your patients. Sometimes they don't really have a voice, or they might not have the energy to actually voice. So maybe just communicating, building that therapeutic relationship as well, to know your patients and understand what's meaningful to them. I'll always remember that one. There's always, do you always find that there's just some cases that really stand out and you go back to over and over again?
But it's also balancing up, finding out what that patient. What I'm going to be an advocate.
Go for it.
Not an advocate. I'm going to be do the opposite discussion, the opposite point.
Debate.
Yes. No,
devil's advocate.
Yeah, devil's advocate. That's what. Thank
we're
you, Chris.
tired.
That's what
You can tell we're tired.
Devil's advocate. By just saying that, sometimes that patient wants to do something, which is what we want to encourage them to do, but that's maybe not the thing that you would think, or it could be an element of risk.
Unsafe.
I've had it's unsafe. I've had somebody. I remember a lady who had MS, and she was just so desperate to try and maintain her standing transfer, but she was so unsafe.
Yeah,
she was really unsafe. And it was like, well, if we make the chair, we've got the chair with the drop down arm, the comfort with the drop down arm. If you have that chair, you can still do your stands, but in times when you're tired, you can then do lateral transfer and just try and de-risk it, really, because I didn't want to take away what weight bearing capacity that she had, but she was really unsafe doing it that way.
That really lands quite well with someone who's just popped a question. So an anonymous. Hi, anonymous. And what are your thoughts on getting patients to keep a diary of their activities of daily living and energy levels, so you can advise what time of the day is best to perform certain activities? So maybe it was about opening this lady's eyes to, is there a part of the day that is you have those energies and you can do that, and it's that fluctuating transfers as well, isn't it?
I think that's our role, isn't it, to help people manage those activities during the day, so when they are really fatigued, to take that rest, do something. I say this to my mum. She spends the whole morning cleaning the house, doing the gardening, doing the ironing, and then she goes, I have to sleep in the afternoon. And I'm like, well, do a little bit of gardening, have a rest. Do a little bit of ironing, have a rest. It's breaking those activities.
Have a rest in bed.
Rather than the chair.
Yeah, the chair. But it's sort of breaking down that day, isn't it? And restructuring for people, so that with energy conservation, they're sort of keep conserving their energy to do something that they want to do.
Don't take her siesta away from her though. I'd love an afternoon.
We should have one today.
I think we need one today.
She's always like, by the time
the beds over there.
By the time the afternoon comes, she says, I'm asleep.
But that's really good. So with dieting, You know, sometimes it's good to
Tracking.
write down, and you can visually actually go, oh, that's why I'm not losing weight. So a track like that
is really good.
if somebody does do that, they'll visually see.
It is actually a thing.
That's why I'm tired. Or
it is a thing. So when I did some, when I was a student, I was in the pain management in North London. I can't remember the team, but we had a diary. So it was across that week, and the person would write exactly what they're doing and then color code it. So it's a traffic light system.
Okay.
Red really did not have energy, green was you had energy, yellow, etc. And then they could review that over that week, and then let's like split out the tasks. Let's break the day. So in the morning do one task, in the afternoon do another, maybe leave one heavy task to one day and the next heavy to the next day, etc. So
I know if I've got a big list of to-dos, the way that gets me started is to do like a menial task, you know, like an admin task, and then I've got that, tick that off my list, and then I can go into something a bit more
get the dopamine hit for ticking,
and then go into something a bit more meaty.
I'm not, because if I do that, then the meaty ones I'll never do. So someone taught me to eat the frog.
Do the meaty one first.
Do the meaty one, and then you're like, wow, got that done, right, let's do all the little ones. And then it's
break it up.
I do the little ones, then the big ones.
Yeah, do a little
I never
one,
get to the big
do a big
ones.
one.
Try that, flipping it, because that is, I don't do it that way. I do it the same way as you, but then the meaty one becomes really urgent.
And you don't have the energy.
Yeah, exactly.
So it's about setting that time away to have that, give that person that energy. So if they're full of energy, then great.
Yeah.
If over the weekend they're resting quite a lot, then Monday let's do the big job. Yeah. Funny enough, we were talking about to-dos because we're trying to prioritize our own work and make a priority list. So you have your reds, you have your greens, you have your yellows. Again, I hope maybe this is the same person, but what about the challenges of using your energy for therapeutic interventions, but the toll takes away from other meaningful activities such as being available to play, be alert with their children? How do you find that balance?
Great question. Who's that? Is that anonymous again?
Anonymous. Is it the same anonymous person?
Maybe. That's a great question.
So let me say it again.
I will say that again. Processing information. So what about the challenges of using energy for therapeutic interventions? I think we have the answers to this one. So, but the toll takes away from the meaningful activities, such as being able to play, to be alert with their children. How do you find that balance? I think the key words there are the one, Hollywood. Are you listening? Meaningful activities. And it kind of brings us back to the beginning, right?
And the therapeutic.
Let's make that therapeutic intervention meaningful.
Yeah, that's
Let's make the intervention, get the children involved.
So if you're working
Chris is like,
no, I'm the uneducated one on this desk. So like that's a big learning for me, because I'm just thinking, as that question was set out, it's like I can imagine someone having to practice standing or practice sitting balance, and that uses their energy up, and they can't play with the kids.
Get the football out, throw your football.
Do it with the
throw
kids.
It with the kids.
Interesting. Okay.
Or working on sitting balance while they're sort of playing with the children.
Exactly. Yeah. Or just get the kids involved in doing those sit to stands. Like it's a bit of a game, right? Kids love to play games.
But what if their meaningful activity is watching Love Island?
That's not a meaningful
activity. meaningful in anybody's
My cousin was on Love Island, so I can't go into. But watching the football, that is meaningful when I won't hear
what
it.
that is? What that is, Chris, is actually having rest to then be able to engage and participate in those meaningful activities.
So everybody's got to look at their 24-hour picture before Monday, early hours of Monday morning. How are you going to manage that?
How are we going to manage Tuesday after Monday evening?
Wait, is the game not on? No, I'm Irish, so I'm going to sit back.
It's 1 a.m. Monday.
It's 1 a.m. Monday morning. So are we going to look at our 24-hour picture and think, right, I'm going to have to stack up on a little bit of sleep before.
Go bed early.
Or I'm going to go to bed early to wake up early.
Think about the tasks.
That debate was actually on television this morning. And around, do the kids go to school or not go to school? And that was the question. Do you record the match and then just get up early and watch the match?
That's a very good idea.
So it's about how do you adapt it?
Who wants
Chris
to do what?
Like that's what we're doing.
Well, because I'm literally in my headspace is like how I can't be doing that 1 a.m. jobby. If I could record it and watch it the next day.
But some people will, some people won't, and that's you know, up to them.
Yeah.
And so it's going back
and-
to that person, isn't
and
it?
it brings
it's
us
that person. Yeah, definitely.
brings it back to that activity, right? And that traffic light system.
Yeah.
How do you make that day work for you and your energy that you have? We're
Can't
really
believe you
going off
brought
topic
football
here,
into
aren't we?
it.
I know.
I can't believe we've got, well, it is
Crowbarred
World-
football in there
it is
somewhere.
the World Cup, and yeah, I don't think we'll get told off for bringing the World Cup in.
Well,
I know Jane's got my back. Big football
Yeah,
fan.
get in there.
oh, but yeah, it's all fun and games, isn't it?
Mm.
It is.
Yeah.
I'm just wondering if anyone else is going to add any more questions. Please do pop them into the chat if you have any more questions. And yeah, I mean, just going back to the work that we've done then, I suppose, over the last couple of months and the different blog posts that we've done. So it was clinical reasoning in adult health, so making our thinking visual with Jenny, and then we've looked at person-centered care, which we've definitely had a good full debate on some time ago. And
I
mean,
think into your clinical reason, isn't it, is to, you know, if you're clinically reasoned for a chair or something, is to bring in, you know, what it means to that person and what they can achieve by having that seating in your clinical reason. If you can make that clear to who you're applying funding for, it adds a little bit, you know, that quality of life that you're going to be able to get from seating for somebody.
Yeah, and again, if we think about that person across that 24 period, we went to a really good talk this week, didn't we? And you know, we can try and achieve that gold standard, but actually, can that person tolerate that? Is that important for that person? How do they feel? What is it that they want to be able to do in that moment or in that chair? I'll always go back to, I mean, I'm probably not going to do the story quite well because it's Jenny's story, but she had a patient and he had quite complex postures. And all he wanted to do, sorry, I'm bringing it back to the football, but was to sit out and watch the football and just to be comfortable in doing that. And Jenny's clinical reasoning was that was only going to be for a short period of time. That wouldn't impact his posture majorly. So it was going to be meaningful for that person, and it wasn't going to be putting him at risk of further deterioration for that short period of time. So let's allow these people to engage in what they find meaningful.
Did either of you catch? I know you weren't there, Saz, but the Anita Rush's workshop.
Yes.
With the
bariatric?
on the floor. So she actually had her living room. Mapped out on the floor with tape.
Right.
And then she had a bed, a chair, a hoist, a sling, had her fireplace, had the bay window, had the door entrance, and then got all of the participants in there, split into two groups, said, right, set this room up. And I thought it was so interesting. There was one team had the chair around a different way. And she said, one thing you need to consider when someone's coming into that room, that patient can't see who's coming in. So someone's coming in, hello, and they can't get to see where it is. If the chair's here, you can always feel safe in that direction of travel. I thought it was so good.
It was really good.
It
really got everyone thinking. And you know what the big thing was as well? So we come into that space. It was run over 2 sections, but we come into that space and we're like, and as clinicians, we were like, well, it should go there, it should go here, it should go there. So it was the bed, it was the commode, it was the hoist, it was seating for a guest. It was the fireplace, as you say, all these different elements that someone would need in that 24-hour picture. But then, and most importantly, we didn't ask the person, what do they want? What did she want? She wanted to look out the window. She wanted to be able to see the television, and she wanted to have a Christmas tree
in the window.
But she was
See, I'm all over that. I
I'm
would
up for
brought
that.
that up.
But what's meaningful? What does that person want to do? Right?
That's so true.
That's really good.
Hi, Anonymous. Great suggestion. So, however, some patients, sorry, Jane, my brain, I'm not going to pronounce.
Serendipity.
No. Some patients.
Circadian
Circadian
rhythms. Yes, are back to front and are awake during the night. So have little to no energy during the day for therapy. Any ideas on how to address this?
Just one question would be, are they definitely going to bed at night? And it's going back to that sleep
cycle.
And how good is their sleep? And addressing that first, because
what's keeping them awake?
Because a lot of people, I say a lot of people, that's very generalized, people that I have seen over the years, they sleep in their chair during the day. You know, you've watched whatever on TV, Loose Women, and then you fall asleep. So what are they doing? Are they falling asleep quite a lot during the day and therefore not sleeping at night? So it's looking at that 24-hour picture.
Yeah.
And is that you've got to find the reasons why they're
get that
traffic
word
rhythm
again. Get that.
There's
it's multiple reasons, isn't it? Why somebody is awake during the night.
Well, there's like
hormonal medication, or loads of things that could keep people awake. So when you go in as a therapist to try and do therapy, they haven't got the energy to do it. So
So in Q1, so in the first couple of months, we focused in on that sleeping in a rise recliner, and one of those webinars that we did was actually sleep and sleep hygiene. So it's about breaking that down. So I'd encourage you to maybe watch that one back. It's a really good session that Jenny did. And it's looking at that picture from a holistic point. So it's not just, they're not sleeping. Well, why? Why is it they're not?
What was the question?
The client group that this person's working with?
I'm not sure, but anonymous. If you have the client group, then we might be able to help.
Obviously, a lot of people with dementia, they lose their sort of orientation to time, don't they?
Sundowning as well.
Orientation to time.
My mum is literally the archetype of that patient. She actually just retired on the 30th. More childcare, yes. I'm glad she's not watching.
What's your mum's name again?
Carol.
Oh,
Carol. Love you, mum.
We're going to send her this recording.
Don't. She retired on the 30th, but she would literally work she started at 6 a.m. She'd work like 6 to 11. She'd get in, she's exhausted. She would then have a really big nap, and then she wouldn't go to bed till 11, 12, and she wouldn't sleep for long. And she was in that circadian rhythm. She was in that cycle for maybe 20 years of just doing that. So now she has to sort of break out of that.
Yeah.
I'll send her Jenny's webinar.
Do that.
Honestly, we all need to do a bit of sleep hygiene.
Yeah.
I do. Last night I was up late and I'm like, now I'm tired. I'm like, well, why didn't I go to sleep earlier? Because it was on my phone or
I find on a weekend I stay up later because it's the weekend. And then Monday night I struggle to get to sleep.
Yes.
For that first thing. Once I've got that, then I'm fine for the rest of the week.
They say that if you get up at 6 o'clock Monday to Friday, you should do that Saturday, Sunday.
Yes, exactly.
Yeah, so having that routine, that structure is super, super important. Because we were just, full of conversation, I almost missed Mel's question, which was a pre-submitted question. And Sarah, I'm coming back to you. So how do you approach skin inspection for residents who do not like to be touched or examined?
Yeah.
I always find this difficult and wonder what your advice is for that.
So there's questions around that. As if you know me, you'll know I'll ask a lot of questions. And
then say it depends.
Yeah, totally sit on the fence.
So I'll give an answer this time.
Yeah. So we had this a lot in the community because we have to do a body map to show, if there's any wounds or anything like that. And the question was, if you've got somebody who, say they've got leg ulcer or whatever, and we have to do this body map, and you can't just go into someone's house. Sometimes we're going into young people's houses, and you can't just go, can you show me your bottom so I can see that there's nothing there. So actually asking that question, do you have any areas that you're concerned about? But I think if you could write a little bit more information, I'm thinking you're from a care home. So if you can give me a bit of information on, is it, are they immobile? Is it what was it? They don't like being touched or examined.
Yeah.
If they've got dementia or something like that, it's doing that whole low and slow and have a gradual approach. Maybe it's, no offense to who is caring for them, but maybe somebody else has a different approach that resident might feel better with.
Male or female?
Male or female.
Yeah.
I think it's also doing other activities, isn't it? So if you're helping them go to the toilet or whatever, you can quickly do your skin inspection there. Washing and dressing practice, I know.
Yeah.
We used to do those a lot. And then
just a quick look over.
You find something out, and then you can.
But what if it's just, so let's role play. I'm your patient.
Yeah. Show me your bum.
You want to see my bottom? No.
Okay. Well, do you have any areas that you're worried about?
No, I don't, and I'm not showing you.
Okay.
What do you do? You can't.
So I'm going to give you some information.
Maybe it's the time of day. Maybe they're tired.
Yeah.
So let's revisit it.
Maybe he's just
An
cantankerous.
What are you going to say?
And would you give?
But
You
I'd
need
give
to
you
give
information as why I'm asking the question and why I think you're at risk of pressure damage and why it's really important to take little ideas of what your skin's telling you as to what potentially we could prevent in the future.
Okay,
Looking
I'll
at
show
that
you.
I'll give you the
24-hour
answer.
picture. And that 24-hour picture,
Yeah.
it could be.
Yeah.
So how long do you sit in that position?
Yeah.
You know, do you get up and move?
Yeah.
And
And there's loads of
the
guidance out
risks.
there. We've got seating guidance from Society of Tissue Viability, and that I'd give you that, and then you can read it all and digest it in your own time.
One of the best ones I used to use as a product specialist is I would go in and be like, I'm just, I'm uncomfortable by the end of the day. And I would talk through their day and they'd say, yeah. So I get up at 9 a.m. I'm like, okay. They say, get in a chair. I'm like, good.
Yeah.
That's it.
Then what?
And then what? And then literally, I'm like, so are you using backrest recline? No. Are you raising the leg rest? Are you using tilt in space? No, I'm not. So that how I used to describe it is, I remember there's one gentleman, he said that's what he was doing. I said, okay, what's the longest drive you've ever done? He said, oh, I've done Essex to Edinburgh before. And I'm like, okay. And when you got out of the car after that 9-hour trip, 10-hour trip, how did you feel? It was like, oh, horrible and aching, my bum was sore.
Yeah.
You're doing that every single day. You're
Yeah.
driving from Essex to Edinburgh
Yeah.
because you're not using the leg
It's
rest
a good
elevation.
analogy,
You're
Yeah.
not offloading. You're not.
Great analogy. I love that.
yeah.
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 I mean, I would say as well, for people who don't like to be touched or examined, sometimes it's about that sensory need, isn't it? And sometimes it's maybe behavioral challenges. So maybe like picture boards or
Yeah.
storyboards
Yeah.
or
That's why more information, because there's so many scenarios where you might find that somebody doesn't.
And people that are really, really at risk, people maybe have had spinal cord injury and they're not getting that sensory feedback.
Yeah.
You've really got to drill it home to them, haven't you,
Yeah.
about the risk and,
But often when you've got residents that you care for anyway, that if they're dependent, you do that visual guide anyway. So it's, I wasn't sure kind of what resident, if it's just
so
a
actually,
case of someone's got dementia but they're independent and you can't see, that's tricky. But it's just a case of noting down what you can, having a view when you're doing an activity with them, that sort of thing. But,
and again, it's really about knowing that patient, isn't it?
Yeah.
It's knowing what's meaningful. But I'm going to go back now, guys, back to anonymous, if we can get our brains to go back to that sleep challenge. So this client, we were asking what client group, so being so complex, possibly due to many factors, would you involve other specific members of the MDT to help you investigate? So if so, what disciplines? It feels like a minefield and I wouldn't know where to start. And then I think someone else has added, so maybe sleep trackers like Whoop, Fitbits or Apple Watches. Or a Garmin.
This is the person who said that the person's in that circadian rhythm.
Yes,
use technology, definitely. You can get everything that tells you how and what great sleep. Was it Mark Shires again come back and he said he was so tired after
10.49 hours.
Look at my 10 hours of sleep I had. So practice
you get Aura rings. I think there's rings you can wear now.
Rings that track the sleep. Maybe that's not so great for the patients, but you could use some of those technologies that are out there.
And I mean the MDT approach, so I probably would look at their exercise tolerance throughout that day. Maybe it is that they need some physiotherapy to get involved to build up some exercise tolerance in the day. Maybe it's Sarah's big one, looking at diet. Are they eating a healthy diet?
Absolutely.
Do they have good energy to healthy nutrition?
Are they drinking
medication?
Are they drinking enough?
Are they drinking
hydration
enough?
If you don't drink, if you're dehydrated,
weather.
you're lethargic.
Yeah, especially in this weather as well. And if they're up watching the football in the middle of the night,
It's using your MDT.
And think about all those elements of the MDT and what each element.
Which ones specifically? They said though. What ones? Who's going to be really important?
So the physio, the dietitian, like the speech. How is their swallow? Are they eating and drinking well? So I think looking at the MDT approach. But getting everyone involved and what could each discipline contribute
and reach out to those technology companies as well, because there's so much more out there. You can monitor how much somebody's moving around in bed, can't they, and things like that, and moving around in the room. You can get those sensors if somebody is up in the room at night.
Like those light bulbs,
PER sensors or something like that. We had a question this morning.
The sensors that you can.
There is a lot. There is a lot out there to monitor. And you know what else we forgot? is checking in with the family,
family.
checking with the carers. What's their routine at night? And a big one as well is fluid. So how are they having a lot of fluid in the evening time as well, which can interrupt sleep cycles.
I hope that's
great,
helped.
great conversations though. We're totally gone off track, aren't we, here today? But if anyone has any, we've only a couple of minutes left in the session today. So if anyone has any more questions, feel free to pop it in the chat. It has, well, I suppose, let's think about our key takeaways from this session today. Chris, you either
this is the last thing in my calendar on an end of a very busy week. So I've just seen 7 minutes left. I'm like,
So think about your 24 approach right now, and what is it that you need to, or think about that timetable, right? What is it that you need to do?
There's a few customers on this call that have seen a lot of my 24 hours in recent days. So I think I just need better sleep. Sleep hygiene.
Go away and have a look at your sleep now, so you can ensure that you can have quality sleep. Think about that mattress. Think about that good pillow.
Do you know what? So I have it's a TV bed. Stupidly, we've got a TV in the end of the footboard, and I thought that'd be great. Then I realised I'm 6'3". I didn't really consider my legs always overhang the bed, and I sleep on my front, and now I can't do that, and I hadn't for a long time. When we was away at the NAIAC conference, I had lovely sleep, big nice pillows. My well, I didn't on one of the nights was not great sleep, but I didn't really realise how important that is.
Absolutely.
Also, I've got a 4-year-old and a 2-year-old.
Yeah, it's quality. It's not. Sometimes it's the quality as well of the sleep, because you go into different levels of sleep, don't you? You have your REM sleep and all that. So sometimes you don't go into that deep sleep. So
and again, I mean, I'm not sure if this person shares a bed, but I know my partner, I don't have kids, but I have to give him a nudge because it just wakes me up. So maybe you just need to get your own bed.
My husband gets mad when I breathe. Stop breathing.
Is it breathing or snoring though, Sarah?
Well, we'll say breathing.
Sarah, what's your key takeaway maybe from this session?
I just it's again going for prevention, I think, and I think it was really interesting when you started saying about your posture and everything, and I think we have to look after ourselves as healthcare professionals as well. We're going out and we're doing all of this for all our patients. And actually, we need to be able to do that. So sometimes just take a step back and think, what about me? How can I look after me?
Practice
so
what
I
you
can
preach.
look after.
Well,
Sarah's literally telling us all to just go sleep.
Everyone needs to sleep this afternoon.
Sleep more,
Friday afternoon. It's blunt, not Friday afternoon. Is it? It's probably
siesta.
The best time for a chat.
Yeah. What about you, Jane?
What takeaways from this session particularly?
In around 24-hour care, if you think about your patients, what's super important to think about when we look at that 24-hour care?
I think it's finding out what they want to do in that 24 hours.
Meaningful activity.
not what is my agenda, not what I want to achieve for them, what they want to achieve,
what they
want enable them to do that, adapt.
Then get them to participation is key. Get them to participate, build up that ceiling tolerance, get the children involved. What is meaningful? What's going to be purposeful?
What are their strengths, and how can you build up the other parts that they're not so strong at to enable them to achieve it?
So anonymous, Sarah.
Yes.
Thank you for your suggestions. Definitely need to learn more about sleep hygiene. So great. And we're really glad that actually that's something maybe you haven't considered, and now you can step away and consider that. And Sarah, good point. Practice what you preach. Then we can be better advisors. Yeah, for sure.
We can't look after all those people if we don't look after
self-care.
Self-care, self-love.
And again, as we mentioned earlier, it's like prioritization and thinking about that person across that daily routine is how can they make sure that they're doing their activities across the day and not just one big chunk of work. But it's nearly that time. Sorry, we have to go now. But thank you everyone so very much for watching. After this session, as we said, this has been recorded, so it will be sent out to all. And our exciting 24-hour care pack will be sent out to you all as well for some of all those different resources. We really enjoy having everyone on board, so please share the word about our podcast.
And we look forward to
we look forward to having you back. And if Victoria's out there, we'll get you on the next time to have a sing song. Thank you all so much.
Get some sleep.
Really Oh, go get, yeah,
Yeah.
Millie, we'll
Thanks,
get some
Millie.
sleep
Thanks,
now.
Millie. Have a good weekend, everybody.
Yeah. Bye bye.
care.
Thank you
Bye.
all.
Bye.